welcome everybody. It's great to have Dr. Christian LoBue, who is at UT Southwestern Medical Center. He's on a K training award, and I'm one of the mentors, and he had wanted to come and visit, so it's great to have some interactions. And Christian, tell us a little bit about what you're going to, about yourself and what you're going to discuss.
Of course. Hi, everyone. So I've met a few of you now, but for those I haven't met, I'm a neuropsychologist at UT Southwestern Medical Center. I have a program of research that is near and dear to my heart on potential long-term effects of traumatic brain aging. So that includes risk of developing Alzheimer's disease, other types of dementia, also chronic traumatic encephalopathy. I do have another area of research that's been growing and developing. That's neuromodulation for cognitive deficits in MCI, and which I'll talk a little bit about the end, because we're actually bridging that side with the TBI side of research. So in terms of financial disclosures, I do receive research from a few organizations, including the NIA for the K23, the Alzheimer's Association, the Department of Defense, some of which is related to this talk. I'll be presenting some findings from some of our early work that were actually used as pilot data for these. So there are going to be four main content areas that I will be covering, really meant to go from what happens with a traumatic brain injury. Hereafter, you'll just hear me say TBI for short. I think most people understand what that represents, because I think it can provide some important clues to the potential later life effects. But then we're going to be looking at what exactly evidence we're seeing for TBI being a risk factor, and then the possible pathways that could be linking TBI to being a risk factor, so biological pathways, that is. And then some of our current and future research directions that we'll be taking. So to start with, and I hope y'all can see on Zoom or whatever platform this is, the title of the paper by Chris Giza and his crew, because they've been at the forefront of identifying the biological cascade of TBI. And really it's been well validated now at a cellular level. The neuron becomes depolarized and leads to this indiscriminate release of glutamate, causing this ionic storm, if you will, with connecting neurons. And the cell, in an attempt to reach homeostasis again, the ionic pumps become overactive, and in the process deplete the stores of energy for that cell, leading to what's called a glucose metabolic depression. And it's really at this point where an individual or a cell is more vulnerable to the effects of a secondary injury, but it's also a state where the neurons the functioning is disrupted. And so what effects does that have associated with symptoms or some sort of other biological effects? So this certainly, at a cellular level, what we see with TBI, and really we see with all severities of TBI, including mild TBI. But there are also some other, I think, key features of TBI outside of even a cellular component. And so some of the work by Victoria Johnson, who's at University of Pennsylvania, they have a really interesting model of mild TBI. And I say interesting because they use a rotational acceleration model, whereas many other types of models are really either weight drops or head impacts of some sort. So this is a model that really mirrors many of the injuries that we would see, like with a motor vehicle crash or even sports type of injuries. And they subjected pigs to this type of injury, and immediately afterwards they noticed changes in like feeding behaviors, these sorts of things, that would be symptoms of an injury. But then there was recovery, and then they autopsy the pigs at different time points. So whether it being 6 hours after injury, 48 hours, or 72 hours, gross examination of the brains, there was nothing remarkable. There's no edema, no hemorrhage. They looked normal, just on a bird's eye view of inspection. But they stained tissue on the side of the force as well as the contralateral side, looking to see if there were fibrinogens, so these large proteins, if they were found in the tissue itself. Now, these are proteins that should not be crossing the blood-brain barrier. So if they're there, that would signify leakage of the blood-brain barrier. And you can see by the illustration, compared to the sham animals, the non-injured animals, at every time point the pigs were autopsied, there was a pretty significant higher percentage of fibrinogen seen in the tissue. And it was both the side of the force as well as the contralateral side. What is even more interesting is that at the sites of disruption of the neurovascular unit, the surrounding neurons and astrocytes actually absorbed those proteins. And I think that spurred some more question of, does that lead to further disruption, dysregulation of the cells, maybe an inflammatory response? And obviously this study is not able to really answer that sort of question. But what it does bring, I think, some light on is that this is a generalized type of injury. So they mapped where in the brains that they saw the disruption of the neurovascular unit. You can see it's cortical as well as subcortical. The most prominent in areas where there was axonal swelling, shearing, but it was also seen in areas where there was not. And even more so where there was gray-white matter junctures. These sort of changes tended to be seen more often. And so, I think the human studies provide us a very solid window into what happens with TBI that we just can't get with the human side of things because we can't control for the many factors that may come about. But there really is a disconnect because we really don't know what happens long term, whether it be in the animal models or even really in the human models either. And so this is just one study of many, and I'm just showing the mild TBI related. These are plasma markers, but there's been work done with moderate severe TBI. Essentially the results are the same. So here we have illustrations of neurofilament light, which is considered a marker of axonal injury, and fibrillary acidic protein is a marker of astrocytic injury, at least in TBI. And I know these illustrations are a bit busy from the paper, but just to kind of boil it down, there were 4 different groups: a mild TBI only group, a mild TBI plus an orthopedic injury group, an orthopedic injury group only, and then a control group. And if you look at the right with the GFAP, you can see that in that acute stage and time frame after injury, for those that had a mild TBI, GFAP was significantly elevated. It remained elevated for days, but within really a couple of weeks, it began to normalize. On the contrary, with neurofilament light, you saw really this gradual increase over time, whereas in the acute time frame, you didn't see any influx, you didn't see any increase. But over the first few days to weeks, you saw an increase, and then it actually remained elevated for a few months. But again, by a 12-month period of time, had normalized. So it brings in a question, really, if we map all of these changes that have been seen in TBI stage within that first year, we see increases. They're pathophysiological markers of injury, but they all normalize. And when we kind of bring into the popular map of Alzheimer's disease and related disorders, the cascade of pathophysiological changes with cognitive changes, does that insult have any bearing or influence on the trajectory? And I think that's been a key question that we've had and many others have had too. And it's really a challenging question because it's a simple question, but a challenging one to study. And the reason why is we're talking about two separate conditions that are occurring years apart, maybe even decades apart. And most TBI studies are only looking at about maybe 3 to 5 years. They're looking at outcomes of recovery. They're not looking at questions related to aging or neurogenic syndromes per se. And you can flip it, and aging and dementia registries and studies, they have well-characterized patients cognitively and maybe even longitudinal trajectories, but they tend to collect very little, if any, information about prior TBI. And so it's not an easy path to try and study the relationship of the two or the impact on two. So our early work, y'all are familiar with NAC and what its positive advantages and disadvantages are. That was really what we turned to for a few different reasons. One, the large sample sizes that it had, but we really wanted to go with the clinically well-characterized sample, but also have ApoE genotyping available. Even though there's limited information about TBI, you can see here, and I'm sure you're all familiar with it. So we really boiled it down to looking to see whether a history of traumatic brain injury that resulted in any loss of consciousness was related to timing of diagnosis or even onset of symptoms. Now, in terms of when that injury occurred, again, we don't really know, so we restricted it to those not having a chronic deficit and those injuries that occurred more than a year prior to their first visit to an ADRC. So we first looked at just the clinical syndrome of Alzheimer's, based off of having a history of TBI. As a group, on average, there's an earlier diagnosis about almost 3 years. Well, we followed up with looking to see if there was any differences related to ApoE4 or if that may have some sort of synergistic association. And what we saw is that there were really independent effects. So having, being an ApoE4 carrier, we saw almost the same magnitude of association, approximately 3 years earlier of diagnosis of Alzheimer's dementia that we saw with history of TBI. And statistically, we did not see an interaction, although if you look at the figure on the right, you'll see that the average for those that had both was lower, and that's about 5 years lower. So it makes us wonder if there's perhaps anything there more to explore that we just didn't identify with that single study. But we also saw it females and males. Okay. We saw it in those that were also identifying it as different groups than white individuals that make up the majority of the NAC data set. So we saw it with black individuals. We saw a similar pattern for those that identified as Hispanic, but statistically it did not reach significance. And it's possible that could reflect just limited sample size available to really kind of look at that. And I think we have some interest in trying to follow up and see if that may actually be a finding if we have a larger sample size. And importantly, we saw it in those that were autopsy confirmed to have Alzheimer's disease, and whether it was intermediate levels or those that had high levels of pathophysiologic change, we saw the same association, approximately 3 years. We saw it also in those with behavioral variant frontotemporal dementia, although the magnitude was perhaps a little bit larger, 4 to 5 years. Interestingly, though, we did not see it with dementia Lewy bodies. There was no relationship with earlier diagnosis. But in MCI, we still saw that association, whether you broke it down by only those having amnesic presentation or all the subtypes combined. we saw, again, about a 3-year earlier timing of diagnosis. So it brings the question, at least for us at the time, if we see an earlier onset, is the whole course maybe accelerated? So is there a faster rate of conversion? Is there a faster rate of cognitive decline? So we again turned to NAC and looked at, over an 8-year time span, what happened when individuals were diagnosed with MCI, the amnestic presentation. You can see here the annual rate of conversion to dementia was actually a little bit lower, 8% compared to 10% for those that did not have history of TBI. When we looked at the survival time, we were stumped really for the first piece of this analysis, because the TBI, having a history of TBI actually was associated with having a slower time to progression to dementia, which seemed obviously unusual, because that would signify it was protective, which didn't make any sense, right? And we looked at, whether that was mediated by ApoE4, ApoE2, you name it. The only thing that mediated was timing of onset. So having an earlier onset of MCI mediated that. So these individuals were really hanging out in the stage of MCI longer, but really there was no difference in the age at which they converted to having dementia. So among those that converted to having dementia, looking at rate of cognitive decline over approximately 6 years, so these would be 6 annual visits according to NAC. And we looked at a few different ways. I only have the CDR sum of boxes analyses here, but we looked at it MMSE as well as some other ways. The same finding was seen across the different analyses. Having a history of TBI was not associated with a faster decline in those that developed dementia. It looked just the same as those without that medical condition in their lifetime. So here's an illustration of this finding. So we're seeing earlier or a hastened onset MCI, but they hang in that stage longer. So by the time they convert and are diagnosed with dementia of Alzheimer's type, it looks to be roughly the same. It's really no different, which the question, one, we're not seeing any evidence of having that as a risk factor is triggering progressive decline. Really all we're seeing as a possible contribution is hastening the onset of manifesting the symptoms. We saw it really across different syndromes and stages with MCI, behavioral variant, FTD, but it wasn't a universal phenomenon. So we didn't see it with DLB, which makes us wonder, is there some sort of process overlapping Alzheimer's with behavioral variant frontotemporal dementia that may underlie why we're seeing these associations? Is it increase in tau, given both their tauopathies? Certainly a hypothesis we have had. I think on the positive side of things, having a TBI, we're not seeing any evidence that, individuals are just having this progressive course that most people coming in asking about their concussions decades ago are worried about. Really, the association we're seeing is that it's maybe lowering the threshold or contributing in some way to lower the threshold.
So maybe we should think about that a little bit.
Yeah.
So on the DLB piece, it was driven by the pathology that you then went backward on, or was it a clinical diagnosis of DLB? Or?
It was all clinical, yeah.
So just trying to think of what would drive an earlier diagnosis if these individuals are slightly less resilient or maybe more likely to show an abnormal area of cognition below the range of normal, then they get called MCI a little bit sooner.
Yeah.
And the threshold for actually having functional deficits to make that second threshold to be called demented they don't have, you know, they don't have something that pushes them beyond that, I guess.
Yeah.
So do you think it's two different sources of cognitive impairment that are interacting to cause the clinical syndrome to happen earlier, or do you actually think the TBI is somehow making you more susceptible to the pathology of Alzheimer's disease?
So I think I don't have any answers other than I think it could be both. If I had to hedge my bets.
You equated TBI and non-TBI for level of cognitive impairment with pathology look the same? Alzheimer's pathology looks the same, or would one have less?
I suspect, and there's some data that suggests this too that I'll show later, that there may be increased pathophysiological changes induced by maybe having TBI. Now, what is that? Is it a delayed effect in a sense? What would be driving that? There's so many different possibilities, but...
Well, how long does that, the first thing you showed with the blood-brain barrier leakage, does that just happen for a short period of time and then you've repaired your blood-brain barrier, or does that last the rest of your life?
It's a no. It could be, right? It could be...
But the pig studies didn't go out that far.
No. There are not many studies that aged animals after injury to be looking at those very closely. So we know kind of at the very acute stage what happens with TBI, the pathophysiology of it, but long term, with recovery or not, we don't really know. So it's like this big, in fact, I have a board in my office with a big question mark, you know, with Alzheimer's pathology, TBI pathology in the middle. Big question mark. We don't know.
Anything related to hippocampal sclerosis?
You know, it's possible. It's possible. You know, I think the question of tau, and obviously tau has gotten a lot of attention because of CTE. You know, because we see it with behavioral variant FTD, obviously, you know, a good number of those cases are tauopathies. So there may be something there, and I'll show some data a little bit later to where we're seeing some indications of maybe having higher tau, although, you know, there is a distinction between tau measured in vivo and spinal fluid versus plasma and what that might represent. But,
that piece that David just said is kind of the key component to say, well, is that pathology really being enhanced, or is it actually less? If it's less, then, okay, you have two potential problems.
Yeah. So another question that we've had many discussions about, is it the acute injury that may be driving any sort of risk, or is it what happens downstream? Because history of TBI does not happen in a bubble. Individuals, you know, especially with severe injuries, may have, you know, alterations in their social support, financial status. They may start engaging in poor health behaviors, start using alcohol heavily. So there are many different comorbidities that could develop that have been linked to increased risk of cognitive decline that could simply explain any sort of association with TBI indirectly. And like I mentioned earlier, you know, there have been a lot of studies on risk of cognitive decline after TBI. You know, a lot of them are limited to or relied on billing codes like ICD codes, which, you know, there's arguments about how solid those are and agreeing with actual assessments, but also, you know, many of those studies don't look over a long time period. So they may only look over 8 years, 10 years, and we know that, you know, a disease could have already been occurring. You know, there's, it can start 15, 20 years before there's even a manifestation of symptoms. So sometimes the TBI could simply be the event leading to an unmasking of the condition, if you will. So it may have already been occurring and just went unnoticed. TBI occurs, they get medical help, and then all of a sudden, oh, there's been changes maybe going on for some years leading to a diagnosis. That is all very difficult to tease apart and really probably impossible to tease apart from these types of studies. So we turned to, at the time, the TBI model systems, because they had been collecting outcomes after TBI since 1987. These individuals, as long as they're willing to be involved, will be followed until they say no. So they collect a wide array of information about the injuries. Most of them are moderate severe because these individuals are hospitalized after an injury, then they are admitted to inpatient rehabilitation. And so they collect information at the time of injury and hospitalization, 1 year, 2 years, 5 years, and then every 5 years thereafter. So they have information 20, 30 years out on a sizable number of individuals after they've had injury. Problem is, though, they don't collect information about dementia. They don't have any cognitive measures to look at memory functioning or any sort of other cognitive skills. But what they have been collecting ever since their inception is a functional independence measure that's basically like a semi-structured interview asking about everyday functioning and related to certain cognitive activities, and I've listed them here. And so how we approached it is we developed a reliable change cutoff and looked at, so those individuals that were seen 20 years out after injury, what percentage were stable or improved, what percentage actually declined based off of that cutoff determined by that measure. And we identified there was only 11% that declined. Most people were stable or improved. No one declined between injury and 10 years out, no one declined at both time points. So across both from injury to 10 years and 10 years to 20 years. Most people actually defined between 10 to 20 years out. And we looked at what predicted being classified as a decliner versus being stable, looking at whether alcohol abuse, having repetitive seizures, all the information about the injury characteristics, edema, hemorrhage, seen at MRI at the time of the injury, the duration of the post-traumatic amnesia, all the wealth of the information that was available. And I was surprised. We didn't see any of those medical comorbidities really have any play. The social determinants of health, like social, financial income, social support, didn't have any influence in predicting being a decliner or not either. There's three factors: the time when the injury occurred, which could, honestly just be a reflection of age, given age is the biggest risk factor, the duration of post-traumatic amnesia, and having repetitive seizures. Only those three factors predicted being classified as a decliner. Well, I think the takeaway from this study, as well as some of the other studies, is that, even in the very severe injuries, what we're seeing is that, really about 1 in 10 are experiencing decline later in life. So statistically, while there are associations, the clinical relevance of those associations, when you have patients coming in asking, did my injury long ago, is it putting me at risk? 9 out of 10 is pretty good odds of not having any problems. So I think that's something to keep in mind. The other side is, the acute factors seem to be more associated with predicting cognitive decline from what we can see with this information. So I think that's more suggestion to be looking at those components more closely. Still collecting, all the comorbidities and things and their possible contribution, but at this point, it really does seem that the acute factors, more so than maybe the downstream effects, could be associated with having that increased risk. Now going back to how does TBI maybe serve as a risk factor, what might be going on to lead to a hastened onset of symptoms and some of those other associations that we've seen and others have reported. Here's one of our published theoretical models. It's time for, I think, refinement and some elaboration, I think, on the possibilities of what may be going on. But really our initial work led us to speculate that, at least for some individuals, after they sustain TBI, they might accumulate some biological changes, pathophysiological burden, okay, seen in Alzheimer's and other conditions, so that as they age, if they do develop dementia, they cross over that threshold earlier, okay? So it may be a separate process that just interacts at the time, but it may not trigger, right, an ultimate development of the condition itself. Now, because we see that there's really no relationship of having a history of TBI with progressive decline, we posit that there may be a sensitive time to see any sort of signal, that there may be some plateauing once a disease really takes hold and manifests over time. It may be very challenging to see sort of any relationships biologically or cognitively. Cognitively, though, there have been many studies actually, mild TBI or many different types of classifying TBI, longitudinally don't see any real worse outcomes in aging, which is fascinating. So the other side is turning to really kind of more the lens of the biological endpoints. Neuropathology, given how these conditions are recognized, the gold standard being neuropath information. Some studies have found, at the end of life, having a history of TBI with loss of consciousness, I don't know if this pointer moves, oh, it does move, found in association with having higher amyloid beta plaques, but not with those without loss of consciousness, although maybe close to statistical significance in with the mesial temporal lobe. Interestingly, though, nothing related to tau, and diagnosis obviously wasn't affected at all. I say this, but there are also other studies that haven't found any association whatsoever, so mixed findings. And I think looking at neuropath as an endpoint is a very challenging obstacle because of the indications that in the disease course there may be plateauing at some point where the pathophysiology flattens out, there's maybe no more neuronal loss to happen, and so trying to identify any sort of signal increased burden associated with TBI might seem improbable. So looking earlier in the course with in vivo markers, imaging, fluid, might be more favorable for detecting those sorts of relationships. And interestingly, this was a study done in a small sample of individuals who survived a moderate severe TBI for roughly about a year or more. They performed PET imaging and compared the individuals with TBI to healthy controls that were actually much older, as you'll see about 20 years older on average, and then also to an Alzheimer's disease group of individuals. And illustrated here on the right, that top row, you can see that the areas in blue, that's areas where there's increased amyloid pathology compared to the controls. So cerebellum, precuneus, not surprisingly, compared to Alzheimer's patients, there was less, but there was some overlap here, okay, but also some distinct patterns. So those with having a severe injury had higher amyloid pathology seen in the cerebellum compared to the patients with Alzheimer's disease. So think maybe brings into more of the indications that there may be some overlap, but may not be completely, there may be some distinct patterns there. And this was a more recent study done within ADNI, actually, looking at PET imaging, but also FDG PET, so amyloid and then FDG PET with cerebral glucose metabolism. And they looked at individuals that had basically a CDR more than 0.5, so those with MCI dementia classifications, compared them to a non-TBI group, and what they saw and observed was that those that had a history of TBI had patterns of cerebral glucose metabolism that were more disrupted for those that had a history of TBI, but also there was higher amyloid pathology seen on imaging for those that had a history of TBI. They also looked at the timing of onset, and interestingly, they saw, similar to what we observed, that having the history of injury was related to having an earlier onset of cognitive symptoms by, again, about 3 years compared to their control group. So again, I think it gives some maybe further evidence that maybe increased pathophysiology or biological changes may be driving that association. We looked at ADNI ourselves, but within spinal fluid, we had really some carefully matched groups. So we looked at those that had dementia, Alzheimer's type dementia, searched through the medical history logs, and identified based off of common clinical classifications for mild TBI, like the VA-DOD criteria, and identified one group that had a lifetime history of mild TBI, and then a control group where there was no reported information of having an injury. And they were matched on duration of symptoms, ApoE4, medical conditions. We looked at differences in cognitive performance on, Ray-Vault, learning, delayed recall, trail making test B time, as well as the MMSE. We didn't see any differences in cognitive performance, which didn't surprise us based off of everything else that's been reported. When we looked at FDG PET, cerebral glucose metabolism, we didn't see any differences there. But when we looked at spinal fluid markers, amyloid beta, statistically there was no difference between the two groups, but p-tau and t-tau, we saw approximately 30% higher concentrations of both in spinal fluid for the sample having a history of mild TBI. Now, statistically, it was a trend, but there was a moderate to large effect size when we looked at the effect size, and these are small samples, so sample size is greatly underpowered to see statistical effects. And as a follow-up study, what we are currently working on and trying to write up as a manuscript, we pulled information from the Texas Alzheimer's Research and Consortium because they have blood samples that have been banked. And for the past few years, they've been able to collect fairly detailed information about mild TBI through an interview, similar to the Ohio State University method. And we were able to look at and really derive samples that were closely matched in terms of age, medical conditions, even ApoE4 status across the cognitive spectrum. So those that were cognitively normal, those that had MCI diagnosis, and those that had dementia of Alzheimer's. And when we looked at the concentrations of a panel of markers, so these were all Quanterix Simoa platform run markers, we didn't see really any differences between, these are effect sizes between the groups, orange reflecting higher concentrations for the MTBI positive group, and then blue reflecting concentrations for the MTBI positive group. And those that were cognitively normal, we didn't really see anything that rose to a moderate effect difference between the groups. It was really at the MCI stage, we saw that p-tau 181 kind of moderate effect for there being higher concentrations for those having a history of mild TBI, same as with those that had dementia. But then also at that stage, we saw moderate to large effects for neurofilament light being higher concentration and the A beta 42/40 ratio being lower. And that, you know, we're cautious. These are very small sample sizes, but I think it gives maybe some further indications and support that there may be some biological changes going awry that might be tied to having that history that could predispose some individuals to be vulnerable, and why we're seeing associations we do see in having an earlier onset. So, you know, I think really the takeaways, in vivo biomarkers, I think there's a lot left to explore in those, imaging for sure. Pathophysiological changes at end stage, I think it's going to continue to maybe find mixed results, given the complexities of what may be going on during the disease itself, given it's going to probably be harder to even see a signal there. But what actually would drive the increase in, let's say, tau or any other sort of pathophysiological change is still really unclear. Is it inflammatory processes? Is it metabolic? Is it blood-brain barrier disruption that could have those implications long-term? Certainly unclear, and I think that's what we're trying to go with in future studies. We just completed enrollment, prospectively collecting our own samples, spinal fluid paired with blood, in individuals that were clinically characterized in our clinics at UT Southwestern to have amnestic MCI, and classified one group having a history of mild TBI and a control group with no history of TBI whatsoever, looking at the plans to look at the core markers of amyloid, p-tau, total tau, and if possible some other markers within spinal fluid, but then also in blood, and see if some of our earlier findings we can replicate. And then for the K23 award is to extend it even more so and collect not only blood, but to look at the content packaged within extracellular vesicles for some of these markers. The idea being that within blood itself, there can be a lot more noise because you have cargo circulating from peripheral tissue, not just brain, brain-derived sources. So if we can go more brain-specific, looking at content packaged within extracellular vesicles, perhaps maybe we can have larger signals in being able to identify some of the biological changes that may provide some more clues for why we may see differences in having earlier onset of these conditions. We're also incorporating some neuromodulation. So we have a few clinical trials going on where we're actually deploying neuromodulation as a therapeutic or possible therapy for cognitive deficits in MCI and dementia. But we're employing it for the K23 really as a probe of underlying integrity of memory circuit functioning, looking to see are there any differences in responsiveness based off of having a history of mild TBI. And so kind of illustrate at the bottom, we have some really novel configurations for the electrical stimulation. Very focal delivery to the left dorsolateral prefrontal cortex for one condition, and a very focal delivery to the left temporal lobe for another condition. And it's a within subjects design, so participants will actually go through all phases of the condition and serve as a control in of themselves. And this is just a picture of our lab and some of my coordinators, and Danya's wearing the cap, and it's portable. It plugs into a laptop, so there's even some discussions of maybe some at-home applications if more information is learned about the technology and if it has some application within this area. And so with that, so Doug Glasgow is a mentor on the K. There are some other mentors on the team, Chris Giza at UCLA, John Hart, Monroe Colm, and then Sean McClintock. And I've learned so much from them over really the first year of the K Award, and I'm looking forward to everything else to offer in the remaining years. And with that, I want to leave time for questions.